everyone. Good morning, and thanks for joining this second part of this presentation. So I'm part of the team that does machine learning and data science in general for healthcare and life sciences applications. We are located in Haifa, Israel, and working on different types of data, from clinical data, EHR, to more data from more biological data, and also more interesting sensors. And I'm going to describe three, time permitting, I'll describe three projects we have been busy doing recently. The first one, and these are all around causality. The first one is simulating data and which we also use in a competition that took part last year in May. Second one is how you identify and characterize subpopulations of patients who may benefit from specific treatment compared to the overall population. And the last one is looking at the effects of second-line treatment with diabetes and using causal inference methods to estimate the effects. So I may not get all the way through the end, but wherever we get, that's okay. Feel free to ask questions. So before I start, I'm curious, how many of you practice causal inference in your daily research? Around half. And another question is, what type of platforms do you use? SAS, R, Python? No Python. Okay. Yeah, good. Okay. So, I guess we are mainly using Python and students were going through community. So, simulation. Yes, sir. Well, that's a good question. I guess it comes from we are all trained in machine learning. Python is very strong for machine learning, and we're still being trained with this kind of thinking. So we get it as advantages and disadvantages. We are in this causal inference domain for the last couple of years, but we bring with us all our knowledge and expertise in machine learning. That's some of the advantages we share with us. I guess I can ask the same question. Well, why do you use SAS? I guess the answer will be kind of the same, right? You come from statistics or epidemiology, and that's what you use when you were trained, and now you continue using SAS. So, you're slowly adapting. So, I guess each platform has some pros and cons. Python is very intuitive and different views. So why similar data? I guess based on the talks I attended yesterday, I guess most people use simulation sometimes for causal inference. And I guess the main reason is that it's very hard to know what is the correct answer to the question that you ask. Right? You try to estimate some effect. You obviously, in most cases, don't know what's the correct effect, and therefore it's hard to know whether your approach either developed by others, or maybe one that you came up with, it's hard to know how accurate and what limitation it may have. Even if there is clinical trial, for example, that measures some effect, it's again unclear when you use observational data whether you would like to find the same effect, or maybe clinical trial is based on a specific population that it's not identical to what happens in the real world. And then you can argue that the effect that you compute is different because you are looking at the population with different characteristics. Obviously, many things can go wrong. You don't know in most cases what the structure of the total graph or what confounders you will have to use in order to correctly compute the effect. There may be various biases on top of the confounders, and you want to maybe use the specifier and so on. And most of these limitations, you cannot even test in the data whether they exist or not. And finally, even if you have a number and you knew which number you would like to end up with, it's just a single number, right? So, say you know that the effect of some treatment on specific population is X. It's probably very likely you could get this number using different models, different designs to your analysis calculation. So you would very easily overfit. And bottom line, you wouldn't know if you need to write the image. And I'm not talking about having done the code, even about it. So there are many indirect ways to assess whether the approach is reasonable, right? You can take some negative and positive controls. For example, if you know that the drug that you study, treatment you study, does not have any effect on the outcome, you can run your Python and test what the estimated effect that you are compute. And you would expect it to be almost zero, right? That's kind of negative control. You can also take some positive control. There are different ways to do that. I wouldn't go into this. If you do antibody, you can test whether the confounders of violence in the situation are faster using the inverse probability rate. You can test the accuracy of your models of the observed treatment, so not for every patient, but for only one who got the treatment. It obviously has some limitations. But the bottom line, I think that using simulation is a good way to test your pipeline of the causal inference and making sure that what you think you get is correct. Obviously, do not simulate too much because they are as realistic as the assumptions that underlie it. Right? So if you discuss some examples later, but if you assume that there is some function that generates the decision of giving the treatment or not, treatment mechanism function, then it would be only as good as this function is, right? That function is not the one that is used in real world, then the model will be comparable to what happens in observational data, but would be interesting nonetheless. So you can do the simulation in three different levels. I guess the simplest one is to just take covariates that were measured or collected for some population and just simulate the treatment assignment and the outcome given the treatment assignment. Then we can also go one step backward and also simulate the covariance themselves. And finally, we can also simulate the relationships between the different covariance and then simulate the covariance and find the treatment analysis. So the idea here is not to parcel some specific simulation, but build a system that can, given some parameters, generate a large number of different scenarios, and for each simulate the data, and then run different methods of causality of frequency estimation, and in that way, assess the ability of these methods to correctly estimate the effect on the different scenarios. So as I said, the base level is given covariance. We have, for example, take some public data or data that you have with covariance for some number of patients, and use it to decide what would be randomly decided or subjectively decided what would be the treatment assignment for each patient, given some covariance that you decide are confounded, and from this treatment assignment simulate the outcome. And there are different parameters you can set. For example, which covariance used to as a confounder from the treatment modifier, how much noise you would like to add to the system, and so on, and whether the outcome is binary efficient. When you want to simulate the covariance, you would also like, so you assume that you have some noise about how covariance affect each other, and then you simulate given this structure the covariance, and from this you simulate the treatment analysis. So this is just an example of a pipeline. So you start with, as an example, selecting subsets of the covariance as the ones that are confounded. From these, you also select ones that affect only the outcome of the treatment assignment, and from this you simulate the treatment assignment and the outcome after adding some noise as well. So we try this with various combinations of parameters, and so get to this competition. I'm curious, how many of you heard of this competition last year? Maybe participated also? Yeah, that's interesting, because I think very relevant to this community. How many heard about this conference? Atlantic Convolution. Okay, 10%. I think don't do too much PR. Anyway, so last year they had a competition within this conference. I think the next one is actually May 2017 in maybe North Carolina, but I'm not sure. Yeah. So last year they had this causal inference data analysis challenge. So what they did is something similar to our simulation system. So they took simulation system focusing on the treatment and outcome simulation. So they took data about almost 5,000 different patients and 68 different covariates, and these were unlabeled. So I think they also did some transformation of the numbers, so you won't be able to even guess which one of these stands for what kind of feature. So we have this 5,000 patients, 68 covariates, and from each one of these, from this feature and covariate matrix, they simulated 77 data. For each one of these, for each patient, they somehow decided what would be the treatment assignment, but we don't know bias A, and based on the treatment assignment and the covariates, they accumulated the outcome variable Y. And they use the 77 data set, basically different ways of simulating the outcome and the treatment and the outcome ways of the covariates. So differ on the number of confounders, whether the interaction of the confounders, whether the wear of the not. So there was no hidden confounders in this exercise, so it's kind of easier. But the way that the confounders determined, classically determined the treatment of outcome wasn't obviously easier to be system. And one other thing they did, they just released 20 data sets and kept it to the unpublished. So even from this 20, they didn't publish the effect, just the treatment assignment and the outcome. And the challenge was to estimate the effect of the treatment on the treated, both in the population level but also on individual level. So main aim was to estimate on the level and then was the double track of estimating the effect of each one of the patients.
You had a lot of history.
No, so they summarize everything somehow into matrix of data. So we have each patient has different covariates, and it might be that some of these covariates are from the average or some blood pressure or whatever scientific reason.
An off-topic question, but on the sort of data mining sort of literature we were talking earlier about that one. How is the data structured? Because I find like a lot of, I can do any statistics I want if the data comes in a matrix.
Yeah.
You know. But I work with people who do claims data and the data comes in database sort of system where you have the patient information in one database and then you have the outcome information in another database. And I found it like a barrier to sort of using that data, the data structure.
Yeah.
So is this what you guys work with?
We typically work with different kinds of data or electronic health records. So as you said, database with huge levels, different information about lab tests and procedures and appointments and so on. And each patient has a different number of tests and a different number of questions and so on. And it is a great challenge to take this and transform it into the medication. We just the paper accepted to medical materials, something that is describing the tools we came up with that takes data and very not easy, but much easier and much easier way take the data and transform it into so that's actually Jeff on that. So but basically it's challenge. So we have to come up. I thought about it a bit later, but we have to come up obviously with what periods we like to look at and aggregators we call this one. Accurations we want to run in front of the some maybe different time periods, different features. But that's definitely we spent each few years developing this solution and
Do you use like a crosswalk file for logic, or the software, the program you're talking about uses some logic? How do you come up and what are you using as the mechanism to do that?
You mean structured features?
Yeah.
So we our approach is extract as many features as possible. So if you think average should help and a map extract everything, and that's
Do you present options? Or does the program present like different
everything? Well, it has some values for deciding what operators you want to run the data. So it could be time to event, and then you would like to look at the minimum time or the maximum time. It could be about the data.
So the user kind of determines.
Yeah, that's some kind of XML-based interface to some of the parameters. But basically, our approach is that everything is very useful, and then we are bouncing another segment, and then which features are more useful to are more ideally or more associated with it's not a question of causality. I think that's the way we because also you have to be very careful that you don't use too many features and complicated data. Otherwise, making sure that that doesn't happen.
The starting point of all of these data mining, machine learning is still about data matrix. It's the same starting point as for statisticians.
Yeah.
Or do you guys really think about the data structure?
No, I think if you're using what we call static predictive analytics, so you have other problems with data, but you have a paradigm which stands for presence, and then you took your extract features from time period before that, and you predict what will happen next. And it sounds pretty fine for us. So, yes, in this case, that is the construct theory. In other cases, you can use dynamic modeling, and in that case, you can use observations for that along the time.
You can use the name. So the tool called Iterate.
Yeah.
We are making available the IBM open text platform. We call it the network evidence platform. And it's not yet in the market. This particular code is being used. We are making available for some companies in the market.
So just very briefly about the back to the competition. So we use, as I said, we are training the machine learning domain. So the approach we took is we feed it all converted as confounded, and as you do not have any out of the confounded, this basically guarantees that you would block all vector steps. So we use everything. We actually fitted two different models. One is a random forest, and the other one is based on Gaussian processes, which I will not get into, and then decided for each data set which one was better at predicting the outcome, and from this estimated the population level and individual treatment level. And this is what people organizing the competition haven't yet published the full results. This is just a snapshot from what they already published. So they look at different stress measures. First one is probably the most intuitive, is the bias in the prediction versus the RMC, and you expect some, as these two are actually related, you would expect some training. As you see, our method is actually here, so it's second or third best. You would like to be as close as possible to 0.3. So that's when it comes to the bias and RMC. We also started to estimate the confidence interval, and then the coverage, that is in how many cases the correct answer was within the confidence interval, and also the interval length. And again, we are here. You see number 3, I guess. Maybe it depends whether you look on coverage or interval. then also the measure runtime, and this plot here on the right shows the individual level, the root mean square error on the individual estimation. So, here we also. So, and here, this goes back to simulation. So they had 77 different scenarios, and they simulated each one of these 100 times, which is not just one realization of this scenario, but many. And there's all these information. So, yeah, we're looking forward to hear what the final results is, but based on the information they already revealed, we perform pretty good.
And the bar?
Yeah, the bar model is actually the one here. Yeah, that's again. You said it.
I'm there.
Okay. Yeah, it is. But great men tend to believe that it's different group. So it is the organized algorithm, but different group medicine. So yeah.
So for your team to participate in this and come up with analytics, how long did it take?
You mean to come up with the
for your team, you kind of participate in this competition.
Actually, as we indicated later, we don't do too much publicity for the tournament. So we very late realized this competition is running. So we took us like a couple of weeks.
No, we have a team of experts in machine learning, we postdocs and researchers who are postdoc, like Sam, who did his postdoc here in the US and came back with us. So we've got a team of unique experts in this area who looked at the topic prior to the competition and looking for causality independence of the competition.
It's not very good to our so to have some deadlines you have to look at
How long do you think? Sorry, I missed that.
So our team is 15 researchers. Not everybody works on the development, so
the definition of the team is a bit tricky. We have a department in Israel and we have of sponsor people, and we have in New York another large sponsor people, and in California, and we work together in various ways.
Yeah, you're probably building on active solutions that have.
I have two questions. Yeah. How did you determine which interactions to include in the model? Even when interactions choose numbers.
Well, that's one question. So we use models that can infer introduction, even not explicitly identified, and that's how we actually avoid it. You need to specify the introduction. That's it. And based on the results, actually more. I guess maybe one more comment regarding the competition is that a very important reason when you do proper inference is the domain. And here, as the math, we remove the information about the features, nobody could do. So it actually gave advantage to people who know nothing about the domain like us. Right? So it's just a data challenge and not a remaining kind of stuff. So that's also something that you have to keep in mind. Right? If you have, and maybe some other people could look at the numbers and come up with disentangle the transform information and come up with a lot of sensible. We didn't do it. We there has been a capacity on the statistics, but again, if the results for the themselves, and I think it shows that at least if you do not have domain statistics, you can do this kind of stuff.
Maybe random for the interaction with the like that.
Curious, do you have an idea of what the percentage of the using awareness that are actually very connected?
I think well, in different data sets, it's important if you have a number of providers that are using confounders or different, so we just come up with say whether we use 3 providers confounders or maybe 10. But I guess the vast majority are not useful for the but again, you don't know which one are useful or not. Including everybody, every provider actually guarantees that it wouldn't make sense. Obviously, it creates the variance in the principle.
How do you verify your today?
I think everything here will.
I know.
I think I'll go back and check it. I think everything. Okay. More questions about this? Okay, so I'll move forward to a different project. And this is this project was done with a pharma company with UCB. And it has to do with identifying and characterizing subpopulation that may benefit from the use of specific drugs compared to the entire population. So here we have 2 different drugs we consider for patients, and we are not sure which one to use, right? So there's a few scenarios. One is that both drugs would be useful for the patient, and the second one both wouldn't do any good for the patient. In both cases, we don't really care, or the patient shouldn't care which one we use to the patient. And then there are these 2 other scenarios where one of the treatments is actually better for the patient compared to the other, and we would like to give patients in the second row treatment A, in the third row treatment B, as these treatments would result in better outcomes. So, so actually the usual challenges for the treatment that we always have only one outcome for each small sum. And an outcome orientation for each, just one of the treatment choices, and many biases in assignment of participation to patients. And what pharma usually do, that's what they told us, is that domain experts raises some hypothesis as to which subgroup may benefit from a specific drug compared to the other drug, and then tested over the data. Obviously, when you have high-dimensional data with those features, then the number of hypotheses you may want to test increases exponentially, and you might find this program is not just practicing testing the hypothesis, but also how you may use physical problems. So that's the informal way of defining the goal. Now more formally, so we have adequacy of providers or providers. We have the treatment and the right as the outcome, and we would like to come up with a function that, given a small set of covariates, here denoted by m, comes up with a linear function of the m that approximates the odds ratio of giving treatment A versus B or 1 versus 0. So, yeah. And obviously, if you have a population with a higher score, these patients are expected to have higher average score than using this one value of the other. Okay? So we came up with two different scores, or two different ways to come up with to define this F, this linear function. Obviously, the reason we wanted linear function is that it's more expressible and easier to project for F it is a formula or prediction. So the first way is using the Markov structural model, where you write the probability of outcome, the outcome being 1 for patients who got treatment A given some set of covariate terms as a linear combination of P0, P1 times the treatment, P2, this vector of coefficients for each one of the covariates in M, and then again the treatment, and then another vectors time matrix for the effect modifiers. So it's basically the probability is affected by the treatment, by the disease modifiers, and by interactions between these. And when you look on the odds ratios, it's basically so comparing the case where the patient got treatment 1 versus treatment 0, it actually reduces to this simpler form. The reason we have just E1 is P1A because when you subtract these two for A equals 1 and 0, A equals 0 actually you get 0 here, so you get just for A equals 1 and same here. So this is basically the log of the odds ratios for the subset of these modifiers of the end that we are looking for. And if you just take this term, you get a function that correlates with the odds ratio. You get a function that correlates with the odds ratio. So what we would like to do is find a set of variables M that have maximal unneeded effects and include these as the function. So how do we go about doing this? So we use, I think that's probability rating to generate a balance oscillation for the treated and untreated, or treatment 1 and treatment 0. We start with the empty set of covariates, and then iteratively, greedily actually, we add variables from candidate set that we denote by X tab, and we do it by adding in each step each one of the remaining covariates in X tab to the model by adding two different pairs, one for the treatment and one for the treatment interacting with the one for the covariate and one for the treatment interacting with the treatment, and then selecting the one that has the largest additive effect as measured by the coefficient in the statistical regression. And then we end when we have reached the k number of variables, or when there is no new variable with significant contribution to this number. maybe even for visitors.
Right.
We,
Or just if you're.
yeah. Okay.
What do you mean when you say the most significant difference of the application? Is it like selection or?
Yeah. So, and at the end you output the, you take the coefficient that you got from this process, and this, your score is basically a linear combination of this coefficient with the variables that you ended up having in there. Okay, so this is one way, and few of the questions?
But on the previous presentation, you look at the four questions and you run the regression without them, right? Probably you have a lot of additional level to run very different regressions. Okay. So you also include all of them like a different way with a high-dimensional space. And it wouldn't have affected much other than your efficiency.
Yeah. So you mean here include not just the triggers but also the underloop?
You are including the triggers on step 3.
You mean the oh, I see. So you mean include all x starting n?
Right.
Yeah, you could make it, but you would like to use the x short function with not, 20, well, even 20 is too much, but we usually the number of features we extract is in the sentence, so we wouldn't like to give them money. So we actually set k to 10, so we end up running as much as 10 different features in this function.
So the end that you select is for the alpha model, right? So for the propensity score model that you use in the inverse weight, that is all information.
Right.
So that is all the information, but then the alpha model is your selection.
Yeah, I guess it's better to write here maybe everything. So this was based on IT weighting. The other approach is actually based on standardization. So we basically compute a model that predicts the outcome given treatment, the confounders, and the disease modifiers. So everything, all information you have, or all information you have on X-defined set of features. And then once you have, and for this you can compute the odds ratio, and next you would like to so for each patient you have patient-specific odds ratios, and then you would like, so this is what we call individual odds ratios, and then you would like to approximate these odds ratios with some linear function that uses a set of limited set of covariates. Right, so you have the individual odds ratio computed using standardization, and then you train another model to predict these odds ratios for each one of the individuals using a linear function of the limited set of covariates. So these are the two approaches here summarized in a pictorial way. So we will very briefly for the this is the MSM score based on the ITW. So we will actually emulate randomized clinical trial using the ITW. You build a sparse model, and then from this model you derive a sparse linear model with small number of covariates. And here for the individual odds ratio, you compute the individual odds ratio using standardization, using prediction models on all variables, and then you take a sparse model using a sparse, meaning a small number of features that predict this odds ratio from a limited number of features. And then you evaluate which one works better, and we get there. So we tested these two approaches on use case that focused on epileptic patients. So, and I think this one goes back to what you asked earlier. So we have to come up with an index date, which is stands for present time, and then we extract features from history and predict something at predefined time horizon in the future. So we took as a cohort, we have started a cohort of 135,000 patients. I wouldn't go to too many details on how we define it, but obviously a large portion of the time we invest in this type of project is spent on defining the cohort, defining the outcome, defining the features and so on. This is close work with experts, typically clinicians, that help us define it in a reasonably way. I guess one, so for using criteria and default, you can consider the diagnosis and prescription, age, and so on. I guess one interesting, and I think that, okay, that's an interesting part. It was the data used during the same data. So we didn't have all information about seizures that the patient had. We just had information that the patient actually developed the healthcare system. So we have to come up with a way to compute proxies to disease progression of the efficacy of the treatment of drugs based on what we have available. And what we did is we looked at treatment change. So the assumption is that if the treatment is successful, the patient keeps using it for a long period of time. And if it's not, the patient will switch to different treatment, or maybe add another drug on top of what he initially took. So that's what we use the outcome. Obviously, there are many details here as to what is defined as changes in treatment, whether you include changes in doses, whether if you have gaps between prescriptions, whether it's indicating that the patient is just taking the drug, or maybe just maybe and so on. So there is a lot of details here correctly defining. Again, I won't go into this. It's not the main focus of this talk, but these are all because to go back and forth with the expert, you don't do this.
Yeah. In couple of friends, so I found that, like, your condition 3, those are conditions to follow up. So when problem friends, people get very nervous about conditioning in the future. So they're much more comfortable, exactly. They're much more comfortable maybe doing missing values, or if you're using ARC model, sensor, or so have you?
Yeah, so I guess that's a critique here. I think we could have done in different ways. That's the way. So again, it's kind of getting forward with the expert, and that's the way that it should be defined. So
I thought that IMS database, people who do drug use information don't blink if they have to do conditions about 3, and so it's more people in trouble in terms of
that's a comment, and I guess we could have done it in different ways. That's how we have to use it. So we talked about the outcome, and then for the features of the covariance that we expected, as you can see, we expected very long list of different features, both age and gender, and the type of change in treatment and use day, whether it was new drug or switching of drug taken off the use, what is the position of the drug in terms of the drug efficiency and so on. Some variables related to the epileptic stage, to be used as anti-epileptic drug, other comorbidities and so on. So we ended up with hundreds of different features here. As always, we assume that there are no unrelated confounders, or if there are no unrelated confounders that are not blocked by the confounders that are already in the data. We included the covariance that are almost constant, and to avoid overshooting, this is also something in the government and the community not really like. We included only covariance that were associated with the outcome, and also included the covariance that have strong interaction, strong association with one another. So, and then the time set was used both for the set of confounders and also the set that secondary score. Okay, so this table compares the two approaches in terms of the features that end up selected for each one of the models. So the numbers here are the coefficient in the final model, including all the original data, and the numbers in the parameters are actually here for testing robustness. We repeated this process 10 times using non-parametric bootstrapping, and the numbers in parameters is how many times of this kind of iteration each one of the features was selected for the model. So the strongest one who appeared in both models and has the strongest coefficient is actually some proxy for seizures that was inferred from claims for ER or hospitalization or ambulance with epileptic seizure identity code. I guess it's not very surprising. Also, a strong one was what type of whether the industry treatment and the industry switched previous drugs. That was also basically indicated that the patient was already on anti-epileptic drugs. But I guess it's in part to notice is that most features actually appeared in many different bootstrap illustrations, and the set of features selected on these two models are actually highly. Okay, and then to test whether the scores actually do what we would expect them to do, we plotted these graphs. So here on the x-axis is the score percentile. This one looking at the total score of the patient. So for example, these 20 patient is the top 20 percentile of the score. So these are the patients that the score predicts, whatever score we are looking at, predicts to be benefits most from using the drug. And these are the odds ratios included on the data. So as you can see, and you would like to be obviously as high as possible, you need to selected in the score features that compute that select patients that are actually with higher odds ratios compared to the right? So as you can see, the individual odds ratio here is getting a pretty good selection of concern, and we also tested another variant of concern, but instead of taking the covariance which was more significant, and the model taking the covariance actually ended up taking a model with the highest accuracy. So we call it the MSM available value, and this is the one here in CIMPOD. You can see performance more than the other two. And this one here in gray actually taking individual variables associated with the outcome and testing each one of these separately, and as you can see, with the exception of this one, they are all below the scores. This one is actually for the one with seizures. It's a binary one, so it can only split the population into two, and for the 10% here, it's actually better than the scores that so this is looking on the total percentile, and the other one looking on the bottom, actually the same trend, opposite. And finally, you can also look in Kaplan-Meier plots and ask success probability here. You can think about this as so divided about the indexing plot as a function of sign, and again this is just for the individual loss ratio. The green here looking at the top 20% of patients is actually performing what the outcome is actually better than the one looking on 50% or 100% of looking on the 20, 50 or 100% of the other group. So again, two methods to compute score for estimating the odds ratio in order to identify time durations to benefit more from or time class. Any questions about it? Okay. What do you mean? You mean like
Yes. So one is the last variable is
yeah, so you have to correct for one hypothesis when you use multiple tests. I'll have to look here which method we use. I'm guessing we use oh, okay, so the last case is actually the last 15 minutes or so, more standard program instance project where we wanted to estimate the effect of second-line treatment to diabetes. So, as you know, diabetes is a big issue, no pun intended, and when you look at the standard of care for diabetes, recommendation is actually to start with changing the lifestyle, making some dietary changes and physical exercising, and then it doesn't work to administer metformin. But if that doesn't work, situation is much fuzzier. So there are different classes of drugs that can be administered at this point, and it's not really clear which one is preferred for patients at this stage. So this was actually the question we looked at, and we used as an outcome we looked in the hemoglobin A1C level treatment was run after starting the second-line treatment, and we used the historic database out of which we identified 25,000 patients who were on level and above technology. Okay. And we follow the patient 6 and 12 months, plus minus 3 months following the initiation of second-line treatment. Yeah, and I don't know if you're familiar, but there is a protocol of identifying the patient. We follow basically requiring 2 supporting evidences for a patient being affected by this patient of diagnosis, drugs, and uploading. And there's some issue here of distinguishing type 1 and type 2. But that's actually work on so just as an illustration, so we have the index stage, which is the first prescription of second-line treatment drug. We use 1 year of observation period, and then follow the patient for 12 months. Potentially along the way, the patient may switch to different second-line treatment, or maybe stop taking second-line treatment drugs entirely. And we look both in the terms of hemoglobin A1C, one outcome, and the other one is BMI. And just after the 6 months or 12 months outcome was above the below the 45% threshold. And we looked on 4 different classes of second-line treatment for which we have enough patients in the data. So here we have the number of patients and some statistics on this population. So censored patients are ones that along the 1 year switch of stop taking the index-based drug. So here showing the percentage of the entire population taking this drug, and also the p-value of proportion compared to the entire population. And compared to the other features here, the age, male-female percentage, and number of patients who didn't have BMI for all this. As for features, we use again, I think here we have more impact on different features. Again, from different categories, demographic, insights, properties, socioeconomic status, diagnosis, drugs, results, and another one indicating how long the patient is diagnosed with diabetes, and how much time he or she is on so here we observe the selection bias by flipping the model for the patients who were censored using the answer patient. Goes to your question before in the previous study. And we use to select the set of confounders we adjust for. We use actually 2 different sets. One looking on all confounders, all type 1 and 23, and the other one using the domain expert knowledge, identifying 30 different confounders for hemoglobin and for BMI. And I will also compare the effect estimations using IPW and so the results are actually shown here just as an example for one class. So the axis are the actual measurements, so baseline means, for example, let's look here. Baseline means the average hemoglobin A1C level for all patients taking these drugs in the actually taking these drugs. Right? So this is experimental, empirical average over patients who took these drugs. This is not corrected for anything. And then here it's very clear that there are also experts indicating the 6 and 12 month empirical averages over this exact same population. The dot and the bars show the estimates of the causal effects for the entire population and the confidence intervals around it. And the MTC method is actually meta-analysis of multiple clinical trials looking at this problem. And this task of selecting or estimating the effect of secondary treatment. So this should be treated somehow as ground truth with the disclaimer that it's based on meta-analysis and different clinical trials, different populations, different time periods, follow-up, and so on. So this is what we see on each one of these panels, and then we have this information for all 4 drugs, and again comparing the comprehensive set of confounders to one divided by the domain expert. So this is for hemoglobin A1C, and again comparing ICW information. So tons of information here. I'll summarize this in the next slide, just to show before that the results from BMI. I guess one thing you see is that there is some differences in the levels reported by the meta-analysis and the ones that we estimate. And in all cases, the one estimated by the meta-analysis is actually higher than what we estimate. We think that the reason for this is that the meta-analysis combines data from multiple clinical trials that follow the patients for more than just 6 to 12 months, and therefore the level of hemoglobin A1C increased later on, and that's the reason we have this difference. I guess another interesting thing is that if you look overall, the IDW standardization are comparable. That's pretty much the same results. And also, if you look in the domain expert, the comprehensive set, you get more or less the same results.
So, can one compare across treatments?
Yeah. That's the main issue. So, if you want to compare cross treatment, you should look at the adults and the adults, right? This is from the entire population, asking the question, what would have happened if the entire population took one drug or another? So if you're comparing not just 2 treatments or 4 treatments. So as I said, if you compare standardization and ICW, you see that in most cases the results are compared, but there's one exception to this. Here in this GLP-1, you see that the estimates of ICW are very different from the ones here. We think the reason is that there are not too many patients in this subgroup taking the GLP-1. Therefore, the estimation of the inverse probability weight, and this patient may be in some sense different than the other population. One thing you can say is that the initial BMI is actually much higher than the rest of the population. So there might be a problem of positivity here, which could render the RTW method less accurate compared to this. So we think that that's the reason that we have such differences in this specification, and for most other cases, for both outcomes, the results are actually comparable. So
you're treating each subgroup separately, or so for the ICW, are you using multinomial to make the rates and standardization?
So for our ICW, we use in both cases. So for our ICW, what we do is X1 versus rho. So we use the way in this way for the standardization. We have so we have 4 treatments here. We have three treatment variables, treatment 1, 2, and 3, and these all we have 0 actually. And we are not the first one to do this.
Did you truncate the weight in ICW?
Yeah. So what?
How do you truncate?
I can't remember exactly. Yeah, I think it's probably a 10 or something like that. Just check it. I don't remember the exact number. Let me just see. Okay, so we already mentioned the 2 points here. The last one is the obvious limitations of fusion observation of data to estimate effect in treatment effect. So there may be information that we make just because the data have the clinics that patients went into, that it's not a big issue. Again, the same for prescription. And there may be confounded that are not in data, like lifestyle, but in order for this to be harmful for the method, we also have to assume that what we have in the data is not good as proxy or doesn't go to the data. So, I discussed 3 different projects. One around simulation, the second one is around the whether responded to treatment, and the last one is about this, and these are the people who were part of the projects, and we are continuing to evaluate different approaches for combined machine learning and classical programming methods to address various problems in using observational data to come up with treatment recommendation and so it's the paper is will be so we actually submitted one and got overall positive reviews, but I guess we aren't too high to resubmit again. But we have to take a look. So actually all 3 are fresh and relevant, so it was done very recently, and the papers are in very last stages of submission and review.
So you are exploring database, is that available?
So Explorer is one of the companies that I acquired in the last week and a half. But as you can come up with an agreement with them, or at least subset of the data,
we have this slide, right?
Yeah, for some reason it's not under the folder of the software. I think we will
Yeah, we'll move it in the right folder. It'll all be part of the process.
Yeah.
I wanted to pick your brain on a couple of questions that I have. So, I'm assuming that the larger your database, the more like machine learning methods, whichever it is, in terms of accuracy. The accuracy probably is related to how large your database is. So how has that been worked out? For me, it's like a sample size estimation.
Yeah.
For like, when does it start making a difference?
Well, I don't know, so as the rule of thumb, the more data you have, so it could be more, the more patients you have, also the more deeper your information is, the more successful you are. So to really estimate what the business, whatever you like to do.
Right.
And then, how much data is in how many patients and how deep the data has to be depends on the question you ask. Well, I can say that I wouldn't use the just 100 patients. 1,000 could be good start depending on the question and how many what accuracy of the data and so on. Physical confidence and 10,000 and
And then the next question I have is, with claims data, we're often limited by the question that we can ask if you feel that some of the outcomes are not validated. So there's a lot of noise in either various, like for instance, looking for various different sort of things really bad or have low emission values. And then, my understanding really is like, from an outsider perspective of machine learning is that it sort of assumes perfect information. But there is a lot of misclassification, and usually that's what the statisticians worry about at the moment.
yeah.
So is that fair, or has there been some work on like sort of the impact of misclassification or noise on sort of how these methods are being used?
Yeah. So maybe just to emphasize, the things that we're using clinically, each things we have
Right.
same data. Each one uses claims that EHR has some limitations. So claim data may not have certain results. On the other hand, EHR may
Short-term.
yeah, so when you're in prescription, for example, you have no idea what the patient actually bought the drug and so that would be a data we use. Well, I guess the more I think that the more data you have, if you have enough data, you should and you let's say if the noise that you call it is unbiased with random, then if you have enough data, you should be able to overcome. If it's biased, and then you have to either come up with a model to train it, or you'll get biased results. So even if you have a lot of data, you say missing values, but not missing examples, and you might have getting wrong as bias. Yes.
Just your question, again, on the variable selection for best responders, the variable selection for the responders. So the first step, you are trying to complete a response. You did you went to the next step to find the sort of variable community, small ones, right? And you did just this transitional with relation. What if you can do something like the categorical cut model of kind of forest is do that on the data and see what potential variables you have selected. So you actually what's your take when you have to do it?
I would expect some different definitely, but again, what is relevant with this project is some 4 to 7. What is better about the sense that you can look and as we came up with this tool. Using design flow, for example, would end up too much information you wouldn't be able to lay out to enhance and explain why this quarter for this patient you get X and for this patient you get 2X. So that's the reason we make this statistical information like that. When you are not limited to some of these models that have meaning, you can use black box. I would definitely try to use one shot. As I said before, it's definitely a method of including interactions that I don't know if you're satisfied with and run the policy.
From the event and focus, you can expect something like variable importance and
right.
That's multi-directly reflected the risk of problems.
Yeah, right. So you can identify which variables more important than others. So it's what helps you explain why a specific patient gets score. So it's not just a matter of importance, it's also a design that you need to one for. So it's more just an
Really, the useful ones to elicit the important values you actually go back into the.
Yeah, you can also do something that to this approach with some questions within the class.
Basically, we're going to make the link.
Well, I'm yeah, you want this as an item.
So you can just have putting the things together in different ways. Trying to from
okay? You may respond to that.